I've been tasked to talk about innovative radiation techniques in pediatric sarcomas. Now, just a few important things before I speak about the outcomes and treatment. Now, radiation therapy number one is a local treatment modality like surgery. Sarcomas are generally considered resistant to radiation therapy, and hence the doses of radiation that is required for the effective outcomes for sarcomas are pretty high. And because of the high doses of radiation that we need to use for disease control, there is associated toxicities. So all the innovations in technology and techniques that have come over the years for pediatric sarcomas have been directed towards trying to increase the dose of radiation, improve local control of disease without causing significant side effects of radiation. Now, I will use the example of particle therapy and brachytherapy to highlight the impact of technology and techniques in improving outcomes in terms of disease control and toxicity in children with sarcomas. Now, when we use radiation therapy to treat a particular tumor, there is an entry dose, and in the path of the radiation, you could have some normal tissues that would also get some radiation, and some amount of radiation also is received by tissues that lie beyond the tumor. And this is what we intend to reduce when you're using various technologies and techniques to reduce the dose to surrounding normal tissues and reduce toxicity. Now, what happens with protons and how protons is different from X-ray therapy that we conventionally use is that with protons, the entry dose and the exit dose both are reduced to an extent, because of which the normal tissue that gets radiated is slightly lesser or significantly lesser compared to what you would see with X-ray radiation. And that's the primary reason why protons seem to be so useful in the treatment of pediatric tumors, where side effects of treatment is so important to reduce. Besides that, protons seem to also have some biological advantages over X-ray therapy. So because of the improved conformality, we are able to spare the surrounding normal tissues. Thereby, we would possibly reduce the acute and late toxicity of radiation. Because we are reducing the dose to normal structures, we could possibly escalate doses to higher levels. We could use radiation therapy along with chemo and surgery. We could possibly deliver the same dose of radiation in a shorter period of time. We could also use protons for re-radiation and thereby finally improve the therapeutic ratio. The other implications are that because the total dose of radiation that goes into the body is reduced, which we technically call the integral dose with proton therapy and other particles, there is a possibility that you could reduce the chances of second cancers in the future. And of late, there has been a lot of interest in improving cell kill and also immune modulation using particle therapy. Now let us see what has been happening in the West with particle therapy over the years. Now this is data from the Proton Therapy Cooperative Oncology Group, the Pediatric Radiation Oncology Society, and the European Proton Therapy Network. And if you look at the use of protons and particles for sarcomas, almost everyone now would use proton therapy for chondrosarcomas, osteosarcomas, and chordomas. There's significant use of proton therapy for treatment of rhabdomyosarcomas, Ewing sarcomas, and other high-grade sarcomas. So there is a significant increase in the use of particle therapy for the treatment of these resistant tumors using radiation therapy wherever indicated. So let us look at some outcomes. Now this is data from Mass General Hospital, where they have treated a lot of patients with sarcomas using proton therapy. This is data from 2003 to 2009. That was a time when the equipments were not as as refined as they are currently, but with those kind of machines that were available, with doses of 54 gray in inoperable Ewing sarcomas, the local controls were extremely good with definitive radiation therapy using protons. They did mention a few second malignancies in their cohort of patients, and in another study with a more advanced technique called the pencil beam scanning, which is the more modern form of proton therapy. This is data from the Paul Scherrer Institute in Switzerland, treating patients with Ewing sarcoma involving the centroaxial skeleton and pelvis. Majority of them were involving these sites, and after a dose of 55 gray, which is standard dose, and a relatively long follow-up, the local controls at 5 years was 81%. The other important thing was that they did not have any second malignancies at this point in time, although the follow-up was not very long. Other common sarcoma in children that is treated with definitive radiation is rhabdomyosarcomas, and especially rhabdomyosarcomas of the parameningeal region, where surgery is not possible because of the location. So these patients need to receive a high dose of radiation, and I just wanted to highlight the difference between what happens to the dose to normal structures when you treat with protons here versus intensity modulated radiation therapy. And you can notice here besides the dose of radiation that goes to the tumor, there's some amount of radiation also spills into the surrounding normal structures, which is reduced significantly when you're using proton beam therapy. If you look at the numerical differences, a dosimetric comparison between proton beam therapy and IMRT shows that there is a significant reduction in the dose to the contralateral globe, the contralateral lens, the optic nerve, the optic chiasm, the brainstem, and part of the brain. Literally, there is a universal reduction in the dose to the normal structures when you're using proton beam therapy. Whether this really translates into a reduction in the late effects and second malignancies is to be proven in larger trials. A similar study from Mass General Hospital, the treatment of orbital rhabdomyosarcomas, where radiation therapy remains the mainstay of local therapy, you can see how in proton therapy you could reduce the dose to the surrounding brain tissue compared to what you would see with X-ray therapy. And if you look at numerical values of the differences to the dose to the retina, you could reduce it by almost 20%, optic nerve by another 20%, the orbital bone by almost about 30%. So there is significant reduction in the normal tissue doses with proton radiotherapy. The other interesting thing that was possible because of this technology is to be able to escalate doses from the standard dose of 50 gray in rhabdomyosarcomas to a dose of 59 gray, which is being used by the current COG trials in patients who've got tumors larger than 5 centimeters. And this has been possible because of the ability to reduce the doses to surrounding normal structures. Now, coming to a more resistant tumor, osteosarcoma, this is a cohort of patients from Mass General Hospital again. This included young adults and who had osteosarcomas, and there were 41 patients. A dose of 66 gray was delivered using proton therapy, and you could see the outcomes. In the 5-year local control was 68%, and this was after a median follow-up of 50 months. And patients who had gross tumor resection had better control when followed up with post-op adjuvant RT using protons compared to the ones where proton was used as a definitive treatment. Now, looking at outcomes of proton therapy in chordoma and chondrosarcoma from PSI, 26 children and treated to a high dose of 74 gray. Now, this would be very difficult to deliver using X-ray therapy, and the 5-year local controls were for chordoma was 81%, and chondrosarcoma was 80%. And for overall survival, it was 89% and 75%. So these were quite good local controls compared to what you would achieve with standard doses of radiation that you can deliver with X-rays. And the toxicities, they were not very high. There were no acute grade 3 toxicity, and the grade 2 toxicities were there seen in 19% of patients. This is just a description of the same outcomes that were reported for chordomas and chondrosarcomas. Now, what about the long-term follow-up outcomes with proton beam therapy in terms of acute and late toxicities and also second malignant tumors? We hypothesized that by reducing the dose to normal tissues, you would possibly be able to reduce the second cancers. Now, this is a cohort of 343 patients from Japan treated using pencil beam proton therapy. And after a median follow-up of 8 years, you could see that there was no in-field malignant transformation in the patients who were treated. These were young children. And at 10 years, the second cancers were pretty low. And this shows that possibly with the use of proton therapy, there is a possibility that you could reduce the incidence of second cancers where radiation has been used in children. There was this consensus meeting of which I was a part to look at what would the choices of pediatric radiation experts be for the use of proton therapy for particular tumors. As you can see, for chordomas and chondrosarcomas, there was a consensus that everybody would treat with proton therapy. And there were similar findings for patients, children with rhabdomyosarcoma and Ewing sarcoma. So there seems to be a consensus that there is a definite benefit of using proton therapy or particle therapy for these tumors. Now moving on to the last part, brachytherapy. Now, brachytherapy for the non-radiation oncologist is a way of delivering radiation therapy by inserting the radiation source within the tumor or very close to the tumor. Now, normally it has been used for soft tissue sarcomas. I am going to share with you some of the innovative the use of brachytherapy that we have done for our patients with bone tumors. Now, this is a young patient with a PNET of the radius with a large soft tissue component. We knew that this patient by our guidelines would merit post-op adjuvant radiation therapy, but we were worried about the toxicity of external radiation. So after excision, chemo and excision, we did interstitial brachytherapy to reduce the dose to the surrounding bone, and we were successfully able to reduce the dose to the surrounding bone. We've expanded our indications. This was a child with a rhabdomyosarcoma of the urinary bladder. It was excised and we had to radiate it. Radiation using external beam or conventional radiation would entail radiating a little bit of the pelvic bone, but we were able to do interstitial brachytherapy and restrict the dose to the bladder only, and there was no dose to the surrounding bone. Sometimes when you have reconstructive procedures done with surgeries to cover the surgical defect, it becomes difficult to radiate them, and that's another site where we have expanded our use of interstitial brachytherapy, not only to reduce the dose of the graft, but also to reduce the dose of the surrounding bone. And this is an example of a young patient who had an excision following which we did interstitial brachytherapy, and we were able to successfully spare the bone and also not damage the graft. Another indication of brachytherapy for PNET of the metacarpal bone, we knew that with this patient we would require adjuvant radiation therapy with a large soft tissue component. We did a ray amputation and we did interstitial brachytherapy, and this is the functional outcome that you can see. This is what you see on follow-up, and he had a good functional outcome. So these examples that I showed you, they are all locally controlled, but just to give you a snapshot of our outcomes with brachytherapy, our local controls at 10 years is 83%. And what we have noticed is that over the years, as we have grown in confidence and experience, we are able to treat or use brachytherapy for younger patients with great efficacy. and we were able to reduce toxicity. Our complication rates have been significantly low, and they have been low compared to both external radiation therapy and historic controls of proton therapy. So, brachytherapy seems to be a very effective modality for treatment of children with sarcomas. And just to summarize at the end, using these two examples of innovation of particle therapy and brachytherapy, protons seem to be very useful in terms of disease control when you compare to X-ray therapy. There is significant reduction in dose to the surrounding normal tissues and thereby reducing toxicity. This could possibly also translate to a reduction in the incidence of second cancers. There is some data, but not robust data in looking at the quality of life and functional outcomes. That is a research area that needs to be done. But there are certain uncertainties also as we move into particle therapy. There are dosimetric questions that we need to answer. We are worried about neutron contamination and second cancers. And finally, it's an expensive modality of treatment. Brachy, on the other hand, again, is a very useful modality and produces good disease control in well-selected patients. There are significant advantages of brachy. The overall treatment time is very short compared to what you would see with external RT. You could start radiation sooner. It doesn't, you don't have to really wait for a long time. The irradiated volume is smaller, and that could possibly reduce the toxicity in the long run. But again, there are certain downsides in the sense that there is only a particular volume that you could treat with brachytherapy, and there is, of course, a learning curve associated with this technique. So thank you very much for your patient hearing, and hopefully I should be able to answer some questions at the end. Thank you very much.